As Darby mentioned, I'm a public health advisor with the AIHC National Immunization Program, and just wanted to give you an update on behalf of our program for where we're at now and the call to action for this month. All right, next slide, please. So I'll just cover, looks like what? It's coverage rates from a couple different sources. And then I did want to touch on the campaigns that Darby mentioned, the HHS campaign, and then we also had an internal IHS campaign. So I'll give you a brief overview. And then we'll go into the more recent call to action for this year for improving our coverage rates and including routine vaccines as part of the back to school package. Next slide. So there's two different data sources that we look at for our coverage rates. The primary data source that we use is NIRS, the National Immunization Reporting System. I would imagine you're all familiar with this. It's an online reporting system that requires our partners out at the facilities to actually run coverage assessments within your EHR and then manually enter that information into NIRS. And I always start with that as the preface because I think it's important to know what level of effort is required in order to get the data into NIRS. We do not get 100% compliance within each quarter. I don't think we ever get 100% compliance of reporting. So our data is as good as can be based on the facilities that report for those quarters. Next slide. So this is just a baseline for where we're at. This shows you our coverage rates by quarter for 2-year-olds. So this reflects fully immunized children, if they are fully immunized with the 7 series, the 431, 3314. And I think it's pretty clear, even without a trend line, you can tell that our coverage rates have been on what looks to be a pretty steady decline. And with the last quarter, I think we were right at 55% coverage of fully immunized 2-year-olds in our network. Next slide. So our adolescent vaccine coverage, and this goes back for more than 10 years, but you can see on here that we actually have pretty high vaccine coverage for our teenagers. So this is at 13 years of age, and we're looking at Tdap, meningococcal, and then first dose HPV for girls and boys. We do see at the end there what looks to be a dip in our coverage rates, likely a reflection of the effects of the pandemic. But overall, we have pretty good teen vaccine coverage rates. Next slide. This is similar data to the previous slide, but this actually captures 13 to 17-year-olds. So it's reflecting catch-up efforts before they turn 18. So the trends look pretty similar to what you saw on the last slide. Next slide. This is our HPV vaccine coverage. And, what you could see on the previous slides is that HPV is where we have the most room for improvement. It's not my favorite slide because of the HPV-3 on here, but what you see on here is for first dose, second dose, and then in the green down below is third dose. But really what it should show is first dose, second dose up to date, because the recommendations are for if you start your first dose of HPV before 15, then you'll only get 2 doses. So this can be a bit misleading, but nonetheless, this is what we're showing for HPV. Thank you. This is our adult vaccine coverage. And again, overall for the various quarters, we're doing pretty well. We still have some room to improve on the HPV completion rates and on zoster, but overall pretty good on our adult vaccine coverage. Next slide. And this is similarly for our adult immunizations. This is using our GIPR measures. So this is a composite measure for adults in the different age groups. Next slide. So the next data set that we often reference is NIS, which is the National Immunization Survey. This is conducted by CDC every year. They do a few different NIS surveys. We're going to just look at NIS child and NIS teen. important things to remember is that this is survey data as opposed to what we just looked at, which was actual coverage data. Okay, next slide. So for NIS child, what we're looking at is national coverage by age 24 months. And you can see it's remained stable and high, with over 90% of kids getting MMR, polio, Hep B, and varicella vaccines. We do see that in the last NIS estimates that this probably reflects coverage before disruptions from the pandemic. And just to note, in case it's confusing, that bottom on the x-axis, this is birth year. So if you remember, NIS changed their methodology. So we're looking at birth cohorts as opposed to just looking at it based on survey year. NIS Child is released every October. So in a few months, we'll see, we'll probably have our first NIS that really reflects some of the impacts of COVID. Okay, next slide. And this is just to show you our the data table out of NIS. Of course, we always grab it and look at our American Indian Alaska Native rates on here. Of course, the survey results capture non-Hispanic American Indian Alaska Native, so it is inherently going to be less reflective of the entire population. But nonetheless, that's what we typically get in the survey data. Unfortunately, they didn't have sample size large enough within our population to have estimates on each of these. And then where we do have estimates, they tend to be a bit lower than the referent category, which is the white non-Hispanic. Okay, next slide. And then this is NIS teen. So our survey data from this past NIS, this right here is our national coverage, all races and ethnicities. As you can see here, for Tdap, meningococcal, and HPV, our coverage remained relatively high and stable. HPV first dose for females and males are, as well as up-to-date rates, are the four bottom lines. They are trending up, but we all have work to do. Next. Next slide, please. Thanks. And then again, if we're looking at, just that one. Thanks. So this, again, the blue box is around American Indian Alaska Native rates. And actually with our teen rates, we have the highest teen rates for all race and ethnicity categories, minus the Tdap, that first one. So what you see in yellow, I just highlighted where our rates are higher than the other categories. So really a lot of great work around vaccinating teens and getting them up to date. Okay, next slide. So the last of the national survey data is the kindergarten survey. This is conducted each year and typically published around April. It is conducted by the state immunization programs. Obviously, the kindergarten survey is going to reflect the coverage for the required vaccines within any given state, which of course differs across the country. But for this, what you're looking at is the percentage of kids enrolled in kindergarten who've received DTaP, MMR, and varicella vaccines. And really of note here is that there was a 1% decrease from, from the previous school year, from the 2019-2020 school year. And that 1% amounts to 35,000 kids without proper vaccination. So again, we're seeing impacts of COVID, and we'll see the next year's survey to see what the impacts were of this past year. Okay, next slide. So I just wanted to spend a few slides talking about where we're at with COVID and what's coming up with our boosters. So this is data taken straight off of COVID Tracker, of CDC's COVID Tracker, that's showing us the impact of COVID infections, hospitalizations, and death. And unfortunately, what we see is that our communities are still disproportionately impacted. We still have the highest rates of hospitalization and death, unfortunately. Next slide. COVID data tracker has gone through a couple facelifts. I find this to be a bit overwhelming to look at, but just wanted to walk you through it. The data is broken out by age groups, and what you see is based on the age group, you can see the population. So if we just look at the top, our 5 to 11-year-olds, we have 28 million kids in that age group, and fully vaccinated. 30% of them are fully vaccinated. Then below that, as in all of the other categories as well, you'll see boosters. So for that age group, it shows you the percent and the number that are eligible for a booster. That's in the hashed box, and then those that have received a booster. So really what you can see is that for those youngest kids, we have low vaccination rates, and then it certainly gets better as you go down the age categories. Next slide. I do think it's important. Sometimes we can look at those slides and numbers and feel like it's all we hear is we got to do better. But I think it's important for us to celebrate when we can. There's been a tremendous amount of effort. You guys are on the front lines, so you're doing the real lift. This is actually now week 89 of COVID vaccines. Sometimes it feels like week 8,000. And we've had 800 million doses of COVID vaccine delivered across our country and more than 600 million doses administered. It's more than 10 years worth of the VFC program nationally and in a year. So in a year, we do, I think, 60 million doses, and 60 million, and now we've got 600 million just in 88 weeks. So I think, kudos to everybody who's out there really doing the hard work. I think an important number to see on here is kind of in the middle there where it says 223 million people fully vaccinated, because that's going to be the group that we'll be talking about that are eligible for boosters. Okay, next. So this is just reflecting within our IHS COVID-19 vaccine jurisdiction. So as you all know, all of the facilities were given the option of coordinating their vaccines through their state program or through Indian Health Service. And IHS has really just come in and run a robust and efficient program for COVID. It's been incredibly impressive. So here, this is reflecting data just within the IHS program. So just the facilities that are receiving vaccine within our network. And the rates are quite impressive. I do want to point out that this is incomplete because it does not reflect doses that are administered elsewhere. So this only reflects doses that are administered within our facilities. And we all know many people who might have received their COVID vaccine through a retail pharmacy or perhaps another facility. So even with that limitation, it's pretty impressive. Next slide. The IHS Vaccine Task Force, they are quite a force to reckon with. They have 357 facilities that are coordinating vaccine. 3.3 million doses that have been delivered to those facilities. And as you can see, it's really a tremendous amount of work that's still going on, even though we are 88, 89 weeks in. So we've got 4 COVID vaccines at this time, 2 that are fully licensed, Comirnaty from Pfizer and Spikevax from Moderna, but altogether there's a mix of 4 different vaccines. So that includes a little bit of J&J and the new kid on the block, Novavax. Vaccines are widely available across Indian country. Okay. So I wanted to give you a bit of an update on fall boosters. As you know, well, you might know at this point, Pfizer and Moderna have developed a bivalent booster. So FDA had advised the manufacturers in June to include Omicron BA4 and BA5. So really what we're looking at is the original formula remixed with BA4 and BA5 sublineages. EUA is pending for both of these. And we expect that Pfizer is going to come out the gate with an authorization for 12 and up, and Moderna is likely going to be 18 and up, although it seems likely that they'll have an indication for 12 and up shortly after that. We don't expect bivalent boosters to be available for children 5 to 11 until later in the fall or winter. It's important to note, well, I put on here rollout in September. So we are hearing that these bivalent boosters should be available as early as the week of Labor Day. So that's coming right up and important to keep in mind. These are going to be new vaccine products. They will replace all the current boosters that are out there. And remember that all people will need to have a primary series before they can receive this booster. So we do want to maintain a primary series footprint. So if facilities want to only have a booster, they just should have something, a place nearby that's going to offer the primary series. Spacing and timing between boosters, we don't know that information yet. ACIP will let us know. But of course, with the booster being available within a couple weeks, we may consider deferring booster doses until the new one is available. That's definitely, just a conversation for clinicians to have with patients, depending on their risk factors. Okay, next slide. Next slide. So there have been a couple different calls to action during the pandemic. The first one is the HHS Catch Up to Get Ahead campaign. This was actually launched in August of 2020. They focused on the Childhood 7 series, and we looked at the rates for that. IHS had 7 clinics participate in this particular campaign. It was voluntary participation, and what they did was they reported on intervention measures that they selected, and then the facilities would submit coverage rates at different quarters. This program lasted, or this campaign lasted for a year. There was a final paper drafted with the results of the campaign. And what I will tell you is that it reflected modest gains in coverage, and that's probably because the pandemic was still ongoing. But just so you know, there are toolkits and a lot of resources that are still available on that website. Okay. We also had a QI initiative within Indian Health Service. So the tagline was Safeguard Our Future, Protect Tomorrow, Vaccinate Today. This was led by a small dedicated team of clinicians working hand in hand with the Office of Quality within IHS. It started in May of 2021. And the focus was improving childhood rates, but also coordinating teen vaccines with COVID vaccines. So if you remember, May of 2021 is when we launched the COVID vaccine for adolescents. And so there wasn't a childhood one just yet for the 5 to 11-year-olds. And we were looking forward to the upcoming school year and really trying to think about how to get kids safely back in person in school. This project also saw really modest gains in coverage at the participating facilities. But just like the other project, there was some interesting information about what measures really were helpful for the facilities. Okay. No, thank you. And then this is the call to action that's come out from CDC for all of us, is really about using this opportunity at back to school to increase routine vaccines and COVID vaccines and boosters. So really wrapping it into all of our efforts in August. It's an excellent opportunity to address all childhood vaccines. We know that all of our rates are still lagging from the effects of the pandemic. Back to school, we might, this is when you have a little bit more interaction, or you may have a little bit more interaction with some of the kids. So thinking about sports physicals and Head Start physicals, or annual checkups and well child visits. Really, it's just about using every opportunity where you're seeing these kids to encourage vaccination, just to get them up to date. And lest we forget the adults. Adults need vaccines too. So the call to action is also to remember that we've got the seasonal vaccines, influenza, and it sure seems like COVID's going to be seasonal. So we've got the booster, the bivalent booster for this fall. And then our routine vaccines. Hep B is now recommended for every adult. Pneumococcal vaccines are new recommendations that came out. So just checking to see if any of our patients need that. Tetanus boosters are still recommended every 10 years. And shingles vaccine is also recommended for all adults 50 and older, and younger adults with weakened immune systems. Next slide, thanks. And, just a reminder, thank you. With most schools now back in person learning, we want to make sure that school-age children are up to date and have received their recommended COVID vaccines. Healthcare providers are the trusted source of information for parents and guardians, so you can help families make informed decisions to vaccinate. Your EHR and your state immunization information system are the most reliable systems to check for all vaccinations. Send reminders to families whose children are behind on well child visits and routine vaccines. Notify families when their children are eligible for COVID vaccines or the boosters, and tell them where they can find those vaccines if not offered at the office or clinic. Offer vaccination-only appointments and hold vaccination clinics. I think we do all these things exceptionally well across our Indian Health Network. And of course, administer COVID vaccines at the same time as other routinely recommended vaccines, if appropriate. Next slide. Just to remind you that IHS has a wealth of resources available to you, so you can always access any of these resources that are most appropriate for your clinic or your community. Next slide. And this is my last slide, just to remind you all that there's more than COVID going on right now. I'm sure you're all intimately familiar with all of this. We have two other emergency responses, just mention them briefly. First, of course, is monkeypox. I know our colleagues here at NIHB are hosting a webinar with monkeypox experts this Friday, so I encourage you all to join that webinar, hear more details, and ask any questions you might have. What I will say, as you're probably familiar, you can see on the graph to the right, this is just pulled off of the CDC's monkeypox website. You can see it's not a promising trend that we're looking at. So monkeypox is not, the JYNNEOS, which is the vaccine being used in this response, is not routinely recommended. It is still risk-based recommendations. But again, I encourage you to join that NIHB call this Friday. And then polio. Polio, we've got the case in New York, and as far as I hear, it's still confined in that area. But just check your status, your vaccination status. Remember, it is a routinely recommended vaccine, and you can check the status of all of your patients in the clinic just to make sure that everybody's up to date. Next slide. And that's it for me. I think that our next presenters are going to have really great information about how to implement a lot of these recommendations within clinics. So I'm looking forward to hearing that, and I'll stick around if there are questions. Thanks.
Thank you so much, Vivian. Jan and Wendy, I will pass the mic over to you two.
Okay, and I'm in the meantime here going to share my slides. So that will take me a moment to figure out how to do this in the right way.
While she's doing that, I just want to thank you, Vivian, for all that information you shared. That was really, really helpful.
There we go. Okay, well, thank you for inviting us. We're also just really thrilled to be alongside Indian Health Services with all of the timely information that was shared this afternoon. So we're going to go ahead and get started. We're here on behalf of the American Indian Health Commission and the Tribal and Urban Indian Health Immunizations Coalition. And so a little bit about us. Well, we were already introduced. I think our bios were read. I'm JanMarie Ward, and
I'm Wendy Stevens.
And so we're going to just move on here. A little bit about the organization that that we work for as private consultants. We work with the American Indian Health Commission and support the work of the Tribal and Urban Indian Health Immunizations Coalition. And the commission is has been established, or it was established in 1994, so it's been long in operation. And that commission is a tribally driven nonprofit organization that has membership from the 29 federally recognized tribes and 3 urban Indian programs in the state. The commission was formed by tribal and urban Indian leaders across the state at a time when it was clear that it was really necessary to have a body to come together and collectively work on primarily health policy issues. And so that was its origin. The commission has continued to work and in the area of supporting tribes and the urban programs in ways where they have determined that there is need and gap. We've focused a great deal of attention over the last few years in the public health arena, including immunizations, supporting best practices, tribally driven best practices. So the Immunizations Coalition has been in existence for quite some time, and that work was originated from tribes in 3 states coming together and identifying some specific needs and priorities that were, and this was prior to actually H1N1, correct, Wendy?
Yes.
Yes. So there was a work group that formed, and they had established some key issues, and it was very much centered around concerns about the health disparities that are experienced by American Indians, Alaska Natives, that make it even more critically important to have access to immunizations in timely ways that are designed in priority settings that tribes drive, not that other organizations drive. So now the Immunizations Coalition really has been a coalition for a number of years now, and it initially formed as this root group, very much led by the tribes and the urban Indian programs in shaping it and how it's formed and how it comes together. So I apologize, my dog is here with me. So the coalition, we center our work around, it's called the Pulling Together for Wellness model. It's a framework. And we use that framework to establish continuity using 7th-generation strategies. We're going to not necessarily be able to go into a great deal of detail about what those strategies are, but we're wanting to give you an overview of what the commission, how it's structured to some degree, and then we're going to talk about some of the actual products that we have supported tribes with. So the coalition, it's a network of partners, community members, tribal leaders, elders, and our focus is to increase immunization rates and prevent infectious disease, keeping in mind that that burden of disease is very high among our population. And so that's what is the momentum, and to understand the critical need to having access to vaccines. Also, our purpose centers around improving immunizations and vaccine access, surveillance practices, infectious disease prevention, and also health literacy. And as you all know, that's been a real factor during this pandemic. Our strategies are tribally driven prevention strategies, and there's where we go to that pulling together for wellness framework. So tribally driven strategic planning, we use that 7-generation principle to do those planning pieces through a network of partners. We also, again, center our work around not just what's happening currently, current time, but also think about that, the historical and cultural context of our population. And then our work is really based upon, we say over a decade, and it's well over a decade. If we think probably back to 2007, 2008, that certainly is well over a decade. This is the framework, the Pulling Together for Wellness framework. And what I'll just share about the framework is that it was developed through the guidance of tribal and urban Indian leaders in this state. This framework has, the initial pieces were developed back in 2011, and we've continued that process on. It's been well vetted on multiple levels, but with elders, with cultural knowledge keepers, with youth and practitioners. And so we've gotten a lot of input in this. There are tools and also components or strategies, high-level strategies, like the use of storytelling to make certain that our data is decolonized, having understanding of root causes, not just the data at hand at a moment in time. That also that 7-generation thinking back to not only the what would be, sort of that negative understanding of health status, but also thinking about root causes and putting a full context to that. And so I'm just going to take you to the center. The center shows that culture is key to all aspects of health. And if you go down below, you'll see something that's called generational clarity. That is a concept, a work, a body of work that is about healing and acknowledging, again, that historical and intergenerational trauma effects and what we do to work with those things, to set out not only the negative trauma effects, but also the strengths that come from within our communities that have allowed us to continue on and exist today. But you can see some other issues there that are all encompassed in that work. But that understanding was that in order to really achieve full whole health, that we have to address those things based upon healing work. And here is the role of the coalition, the Tribal and Urban Indian Health Immunizations Coalition, is to address immunizations and infectious disease, providing a continuum of support for tribes and urban programs that helps to stop the spread of infectious disease, increasing equitable access to vaccines, building confidence in the vaccine and vaccination systems, providing credible information through trusted sources, through trusted messengers, developing strategies to address vaccine hesitancy, again, going back to that broad range 7-generation thinking, not just right here, right now, but what do we know from the past that we can take forward to protect those in the future. providing technical assistance, training, materials, fact sheets, messages, and what have you. We meet on a quarterly basis. We also hold an annual meeting. We work towards building partnerships that are going to support the agenda of the coalition, and also work to ensure that our information is scientifically accurate and also culturally responsive to support literacy. And so what we wanted to show you kind of, pretty quickly early on in our presentation is one of the pieces of work that we have supported tribes in doing. And this is a docustory in response to how tribes at their local level are working on dealing with some of the hesitancy issues. So I'm going to go ahead and see if I can bring this up. I think I can. Oh, good. And here it is. And tell me, can you see a change on my screen?
Yes, it went to the commission's webpage.
Oh, good. Okay. So, and here we go.
We are a gathering people. We gather around food, we gather around
cultural activity, and to be ripped apart so suddenly, it was scary. It was scary what we were losing and what we were losing very quickly.
Because of COVID, there's been a lot of restrictions, so people don't go out. They sit at home, there's mobility, they don't keep moving. And I don't want that to happen.
COVID's not going away. As we get society back to more normal footing, we're expecting to see more cases. The goal of the vaccination efforts are that those cases are very mild, they don't result in hospitalization.
In the beginning, there was a lot of questions about the vaccine. There was this slight sense of unknown, but I trusted my public health officer and what he had to say and the research that I did.
How can we overcome the hesitation to getting vaccinated? We have to build trust.
I actually love telling the story behind the experience while receiving the vaccination. And I expected elders to be served first because that was our priority, elders first. Well, it turned out that we were able to serve elders very quickly, which was amazing. The priority after that was other tribal citizens. Me and my parents, we got to go in together. Dr. Locke came in and he said, all right, folks, does anyone have any questions? Does anyone have any anxieties? What can I do for you? What can I tell you about with this vaccine? And it was just such a relief. I felt so safe.
They took care of families. The tribe has been really, really behind us. I mean, especially when it first broke out, we all got these little kits that knock on our door and hang them on the doorknobs, and they had hand sanitizers, bottled water, different stuff that people might need. It was really amazing. I just can't thank the tribe for all they've done, especially the clinic. Dr. Locke has been amazing.
When you build trust, means you spend the time that it takes to get to know people, to let them grow at their own pace and to accept them for who they are.
The key is to have a conversation, not feel that you're there to impart wisdom or tell them a bunch of facts, but really to find out what are the gaps in their knowledge, what are the things they might have heard that are untrue. People change their minds as a result of those conversations.
I just feel like I've been given so much that it's up to me to protect and take care of those that I love and care about. And when it comes to this tribe, I care about all of our elders and our younger tribal members.
I'm just the kind of a person that really wants to consider what's best for the big picture and for my community. I needed to take care of myself in order to be able to help other people. I wanted to be able to feel that no matter who I was engaging with, that they would feel comfortable with me as well.
We chose to say yes to the vaccine because we go into elders' homes. We wanted to make sure that we were protecting the elders we visit. We are public people. And so we need to be safe for the public. And we are also leaders, so we should lead.
Over the course of about 3 months, the Jamestown tribe vaccinated almost 30,000 people. It was kind of a celebration. You know, people who had been isolating for the last year, you know, finally got to come out, and everyone felt, you know, we were on the road to reversing the pandemic.
You know, we call ourselves the strong and clever people. Let's use our cleverness to build up our strength. That's how we're going to help combat this virus. That's how we're going to help combat the disunity, the hurt, all of the negativity, the social isolation that this virus has caused. We can beat it.
Get vaccinated. Listen to those around you. Do what your doctors, what everybody else is doing all the research for. We care about each other, so let's keep each other healthy.
Okay, now to
COVID's not going away.
just a moment, folks.
Cases. What are the best?
Okay, so thank you, Jamestown Sklallam Tribe, for that incredible work and rounding up just the right people to support that work. We just wanted to show this slide and compliment the National Indian Health Board on the work that they've done based upon the Intertribal World Cafe on health equity. There's a really incredible findings. If you have not seen these yet, I just recommend you take a look on NIHB's website. You know, they're here clearly define a path to equity from a tribal perspective that's really helpful, and also an understanding of that historical piece about, you know, how did we get to those inequities. So I'm going to just take you through. We do have work groups. We have established work groups and task force where we focus on key topics that are brought to us that our membership has said, we want you guys to, you know, help us in these areas. The three things that we're going to talk mostly about today are the healthcare workers, workforce development piece, the childhood immunizations, and vaccination confidence. The workforce training piece, we're working in a project with the National Indian Health Board that is a survey and then some training that focuses on the priority needs of the tribes in the urban programs here in the state of Washington, and then developing some aids for those tribes and raising the awareness about the certification of Board of Infection Control. And I'm going to hand it off to Wendy.
Hi, you guys. Can you hear me? Yeah?
Yes.
Good. Well, thank you, JanMarie. The Tribal Urban Indian Health Immunization Coalition has been just a love of work that JanMarie and I have been able to do together for many, many years with many of the people in the Pacific Northwest. And what's exciting about it, well, there's a lot of exciting things, but we're helping to get the information about preventative care out there to help save lives ultimately. And it's not only the first tribal urban Indian health immunization coalition in the country. It's the only tribal urban Indian health immunization coalition in the country. So some of the things that JanMarie was sharing about the work that we've done and how it was developed and what we continue to do with the role that we do, this coalition model and method, there's about, I believe, about 140, pushing 150 immunization coalitions in the United States. All 50 states have an immunization coalition, and it's been evidence-based that it impacts and helps preventative care, and it helps immunization uptake, and it helps get the information about immunizations out, and all the things that JanMarie was explaining about workforce development and a variety of things that we're doing. This is happening in the non-native communities. And so we moved forward by asks and requests of tribes and leadership in the Northwest to move forward. So it is very exciting. And along came COVID, and I'm going to share some information here about that, where we just happened to be structurally moving this immunization coalition shortly before COVID moved forward, even though we've been around for many years and we did things with H1N1 and a variety of things. Here comes COVID. So we've not only been working in the Northwest, I say that because we're not only working Northwest, but we answer questions regionally. We answer and discuss with First Nations across the border. We answer questions across the country because there are so many tribes, of course, in Indian country and all of our family and relatives, and only one Urban Indian Health Immunization Coalition. So we're happy to do that. We just participated in a webinar yesterday that had the Oregon Immunization Coalition, the Idaho Immunization Coalition, a representative from the Washington Immunization Coalition. These are non-native immunization coalitions, and a state representative from Alaska. And Alaska has identified they need an immunization coalition for the same reasons that tribal leaders have identified for this one. So that's really exciting that some of that's moving forward in Alaska as well. So next slide, here's some information from the Urban Indian Health Institute, who is working with us. It's one of our partners. Jan, if you can move the slide forward. It's one of our partners that we work with on monitoring data, which again, shout out to Vivian for the data that she shared with IHS and some of the routine immunizations as well as COVID, and there are now monkeypox, and even looking historically at polio now. That data is important, and we've learned, as you all know as well, that there's issues for Indian country around data sovereignty, around access to data, around meaningful data, around gaps in data, around who owns that data, what it can be used with, and how meaningful it is for us. So this example right here is from a July 27th, I believe, so very recent report from the Urban Indian Health Institute. And it talks about, I don't know if you can see it, but I'll share with you. It talks about the COVID rate specific to Washington State. So we were just looking at some COVID rates across the country with IHS, but this is an identification of 1,478,263 Washington State residents who have tested positive for COVID. 12,501 American Indian and Alaska Natives have tested positive for COVID, making up 0.8% of all positive cases. We do know that we have a huge gap in data. And so that doesn't mean that is all the cases. These are the cases we can identify that are American Indian Alaska Native specific to Washington State as of the 27th. Race data is unavailable for 70% of all the COVID-19 cases. So in Washington, there's 1,037,348. So 1,037,348 missing pieces of, are those our families and people, or is that from Indian country? Which portions? That race data is missing. There's a huge gap there to inform us of what's going on. The other is the cumulative incident rate of COVID-19 among the American Indian Alaska Native is 4,830 cases per 100,000. And again, this is from the 27th of July, and that's compared to 4,970.7 cases per 100,000 for non-Hispanic race. And you'll see that there's a little bit lower data identification for American Indian Alaska Native, but not much. And yet we're missing a lot of the data here to see the comparison. If you want to go to the next slide, some of that next data on hospitalizations and mortality for Washington State is there for you. And we're happy to share others or this report if you're interested in that, because there's a lot of more detail. And basically there is hospitalization rates is 306.5 of the American Indian Alaska Native compared to 239 of the non-Hispanic white. So we have in our communities a higher rate of hospitalization for the numbers. And then in death, we have 90.8 in the American Indian Alaska Native reported and 72 in the non-Hispanic whites. And again, that is for numbers of 100,000. And those are they're age adjusted. And so there's some caveats to that, and we can include that in the report too. But that speaks very clearly that we still have high hospitalization rates. We still have high death rates, even though we're doing this amazing job. You all are doing this amazing job at getting the vaccinations out there. We just got farther to go to help prevent infectious disease, specifically to COVID. These numbers are in the future. So next slide. And this information is about the role of the Tribal Urban Indian Health Immunization Coalition's work in addressing infectious disease. And one of our partners right now is the National Indian Health Board, and we are today here in this conference joining you. We're happy to do it. Thank you so much for asking us, and we're happy to lift whatever information we have in the Northwest or national information that we've got. We're happy to share that. So if anybody would like that, or information about our pulling together for wellness, that kind of stuff, it's available to you. We are also supporting the National Immunization Awareness Month, which is the month of August. And we have a variety of flyers and information and posters that we put out. Do you want to go to the next slide? And also National Vaccine Week, of course, August 22nd to 26th. So we're supporting that, getting the word out about that. And then next slide.
I just want to just point out that that we're really wanting to emphasize what our role, what the coalition's role is in these pieces. They are on the slide, but providing culturally relevant or culturally responsive messaging, customized messaging and materials, and technical assistance that is in alignment with the needs of the tribes and the urban programs, and especially to increase that health literacy.
So there's a series of thank you, JanMarie. There's a series of flyers that we've built together, and they come from requests over and over and over, from requests in our communities for wanting appropriate materials that help providers and people in the tribal health clinic or tribal leaders, community health workers communicate what the need around COVID is and other vaccinations. And so these here are about the National Immunization Awareness Month. And there's that slide there. Here's another one. Go ahead, about August, the Immunization Awareness Month. And each one has a little bit different message. Like this one is vaccines are safe, and they are effective, and they are preventing serious diseases. And that's because those three things continue to be asked of us. So we lift that information as a trusted source to say, we've looked at this, we have science on this, we have reports on this, we're happy to talk to you. We continue to provide technical assistance, and we have for years. But here you go. Here's three things you keep asking about. It is safe, it is effective, and it is preventing serious disease. We also put, you'll see on each of these, we encourage everyone in each of their tribal communities to connect to their tribal health clinic. So you'll see at the bottom of this example, well, they pretty much will include that a lot, to call your tribal health clinic. Call them today. And this message here says, get back on track with routine vaccines. So we're getting the COVID message out. We're trying to be consistent about the routine vaccinations that we have to catch up on. And we're trying to continue to get the message in ways that we continue to vary the presentations of it so that it captures understanding as broad as possible in the community. Next slide. This one is about we have youth and whatnot. Here's again COVID-19, addressing an issue about, I can get back to my favorite activities because we got asked a lot about that. Next slide. It's back to school time. We started a school work group based on requests from a variety of folks working on issues and trying to get ahead of the needs and COVID impact, coming in September. So we've started this summer, the work group, and out of information and requests from them, we're putting it's back to school and other school information out there. Next slide. This is Vaccinating Children Can, and some messages about why it's important to vaccinate children. And again, that's supportive of the school. Getting vaccinated can help protect children against COVID-19 and, of course, other vaccinations. Heading back to school, another message. Everyone age 6 months and older is eligible to be vaccinated. We know the emerging information around the age came up in June. Here is a message. We do know the vaccine is safe. Again, the safe message, and that it works, and it is the best studied vaccine in history, because we do know that this vaccine for COVID had been studied for some time, as well as all the other vaccines. So we have been carrying and lifting that message about studies and research and how long this has been going on for prevention for vaccine. Here's one about do your report about getting tested, because we get a lot of questions about being tested for COVID, and we're encouraging continued tested. And we are answering now questions, of course, about monkeypox and testing about that as well. Next slide.
And so this is where we actually have a folder of all of the materials that is available on a Google Drive, and we continuously update those on an ongoing basis. But I love our message. We're doing this work for the health of Indigenous people today, tomorrow, and into the future. And I also just have to recognize that this little one over here is my grandchild, J-Lo Cush, and then also other children from the communities up here. So, and then we do have a Facebook page. It's called the Pulling Together for Wellness Facebook page. We have a lot of messages that we also share through that venue. And then of course our website, and there's where you'll find that video that we showed you earlier. And if you are interested in taking a look at any of these materials, you are certainly welcome to. If you need some assistance in accessing them, please contact us. You can contact Ashley. She can help you at any time during the work hours, of course, traditional work hours, or you can contact either Wendy or myself. Thank you very much. And I know that we're over time. So I'm going to just hand it back to Darby.
Thank you, Darby. Thank you, everyone, for your work with immunizations in Indian country.